Good evening, everyone. My name is Jennifer Stretton from Hamilton, Ontario, and I'd like to welcome you all to another session of the Can IBD webinar series. As you all know, Can IBD is a large group of nurses from across the country who are specializing in the field of inflammatory bowel disease and are supported by Crohn's Colitis Canada. And our vision really is to ensure that people living with IBD in Canada are receiving high quality clinical nursing care. Many of you are aware of some of the activities that Can IBD participates in, but we are really a great group of nurses from across the country committed to improving quality of care for people by providing mentorship and leadership opportunities to nurses, creating opportunities for networking and sharing best practices, developing nursing guidelines and standards of practice for nursing in Canada, and probably the most important is elevating the profile of IBD nursing in Canada. I'd like to take a moment to thank our current sponsors for Can IBD, but I would also like to extend a warm thank you and welcome to Jennifer and her colleagues from Ferring Pharmaceuticals, who have generously sponsored this evening's program. I'd now like to welcome our speaker. But before I start, if you have any questions tonight for our speaker, we're asking if you could please put them in the chat room at the bottom or in the QA, and we'll be monitoring that throughout, and we will have a question and answer at the end of the presentation. So I'd like to welcome Dr. Jairath. He's a gastroenterologist and professor of medicine at the Schulich School of Medicine and Dentistry and holder of the John and Susan McDonald Endowed Chair in IBD Clinical Research at Western University. He is based at University Hospital in London, Ontario, where he leads a team providing specialist care to patients with ulcerative colitis and Crohn's disease. Dr. Jairath has numerous publications. He is a national and international key opinion leader in IBD, and we are absolutely thrilled to have him sharing his expertise with us this evening and exploring clinical practice guidelines and the enduring role of 5-ASAs in managing ulcerative colitis. Welcome, Dr. Jairath.
Great. Thanks very much, Jennifer, for the really kind intro. Thanks, everyone, for joining on a nice, warm summer evening. At least it is in Ontario. I don't know about wherever else you are, so I appreciate you joining. And again, just thanks to colleagues at Ferring who have supported this evening. So if you just give me a moment, I'll just get up the right deck. All good?
Perfect.
Okay. Excellent. Okay, so we're, a little bit different, the talk today. We're not talking about sort of new biologics or small molecules. We're actually talking about one of our oldest treatments available for ulcerative colitis, which are 5-ASAs really, and how to optimize those drugs best. And probably as a thing that we forget, I mean, you're all working in specialist settings, right, where you see complex disease, as do I, but you forget the majority of people actually have mild to moderate disease. Most patients with ulcerative colitis, 70% to 80% actually have mild to moderate disease, and they don't even need advanced therapy. But the good news is we have good treatments for them. So we're going to review some of that today. So we're going to look at the optimized management of mild to moderate UC, strategies around induction maintenance of remission, mild to moderate UC, and some update on new resources. So we'll just start with a case here. So nothing complicated stuff that you'll see day in, day out. So 24-year-old male, previously well, presents with increased bloody bowel movements, occasional bleeding in the stool, pain and cramps. It's been going on for 3 months. There's no infections. And there's really nothing else complicating this. He's got no systemic features, no EIMs, no weight loss or anything like that. CRP is normal, hemoglobin is normal, his platelet count's up a little bit, albumin's okay, but the CRP is clearly elevated at 25. And he had stool cultures which are all negative. So, when we think about a patient like this, and the diagnosis here is newly diagnosed mild to moderate ulcerative colitis, what are the goals for treatment of this patient? Now, of course, you've been to many talks, and you'll often see here's the goals for the patient and here's the goals of the physician, and I think the goals are really the same. We just often call them different things. I mean, I think the fundamental goal everything that we do. And I say this to patients all the time, that the main goal is that they can live a normal life and do everything that they want to do and have a normal quality of life. And how we get there will be different. And the tools that we use to measure it will also differ from patient to patient. So that's how I typically frame my conversation. You know, that's the ultimate goal. And to achieve that goal, I'm going to assess how you are symptomatically after a period of time. We're going to do some blood tests. We're going to have some stool tests, and we're going to do some scopes, because the scopes are important to do. And you know, that's the language that I'll use. And but the top of that pillar is actually making sure you feel and function well, and all the things come up to it. I think these guidelines all say the same things, right? You know, we're trying to, patient has to feel better quickly. We want to see normal bowel mucosa when we go in. We don't want them to have complications. We don't want patients' disease to flare such to get hospitalized and so on. But I think they're all really saying the same thing. Now, when we think a little bit about 5-ASAs, and I'm not going to read all of these out, but you know, the story of aminosalicylates for IBD goes back to the 1940s, actually. And I have some slides about the history of the drug, which I haven't shown today, but there was actually a Swedish rheumatologist, Nana Schwartz, who was at the Karolinska Institute, and she wrote the first publication in the 1940s, actually, where she treated patients with rheumatoid arthritis with sulfasalazine. And some of those patients actually had ulcerative colitis as well, and she reported ulcerative colitis got better. And obviously then it took time to know that with sulfasalazine actually has aminosalicylic acid and sulfapyridine, these two things joined by a diazo bond. And when that drug is taken into the colon, it gets broken down by bacteria, and it's actually the aminosalicylate which works for the ulcerative colitis. It took time, many years after, to work that out. We don't use sulfasalazine that often unless people have concomitant joint problems like you see here, because it has side effects. But then you have all of these other brand names. The active ingredient is the same as 5-aminosalicylic acid, but they have made by different companies. They have different formulations, and the key thing is they have different formulations. And those different formulations means they get released differentially throughout the gut and throughout the colon. And you know, there's almost no systemic absorption or minimal. So these are safe drugs, as you know. It's rare for patients to have side effects to these things. We'll talk about what some of the common side effects are. So when we think about mild to moderate disease, there's lots of guidelines out there, but essentially, if you look here on the, let me just see if I can get my pointer up. Wait a moment. Yeah, there we go, laser pointer. So if you look here, you've got mild to moderate disease, and then you look at extent. So extensive is beyond the splenic flexure. Proctosigmoiditis is rectum and sigmoid, and proctitis is the rectum. If you've got extensive, so beyond the splenic flexure, these patients should have, you know, once daily aminosalicylic acid plus or minus rectal therapy. If they've just got distal colitis that we know, proctosigmoiditis, you know, enema and or oral therapy together. And if it's just proctitis, well, suppository for sure, but you know, oral administration as well. And oral is always better than just topical. The two together always better than one on their own. We'll look at that in detail. So this is here just blown up in more detail. Now, as you know, with inflammatory bowel disease, we think of induction of remission, i.e. you get better, and we think of maintenance of remission, how you feel when you take the drug for longer. There's been many clinical trials done now. 54 trials in this Cochrane review. There's probably more studies than that. But you know, as you know, that 5-ASAs are very effective for mild to moderate UC inducing remission. So 5-ASA was better than placebo in every case. But when you look at compared to sulfasalazine, there's really no difference. However, what there is a difference is in the dosing. So for induction of remission, more than 2 grams is better than less than 2 grams. So that's important because we need to give higher dose at induction. And giving the drug once a day is fine, and you don't have to give the drug in divided doses. So I'm going to repeat that message a few times, because you see these patients all the time, and one of the issues is poor compliance. And so one of the main things is when you talk to patients, they'll have been prescribed this drug maybe by the local surgeon 20 years ago who scoped them, and they sometimes take it in 2 or 3 divided doses a day. So they only need to take it once a day, but for induction, it's more than 2 grams a day. So, and again, here's just one clinical trial of many that looked at 4 grams a day versus 2.25 grams a day for induction of remission. And again, you see a big difference between the higher dose and the lower dose for induction, almost a doubling in this particular trial. And then this was a larger, more recent meta-analysis that was done in 2018, and it compared various different sort of agents for mild to moderate IBD. It was a network meta-analysis comparing various agents. It looked at 48 induction trials with over 8,000 people. And the other thing that it showed here was that when you combine both oral and rectal 5-ASA and high-dose 5-ASA, they were ranked the highest compared to other things like budesonide and so on. So again, high-dose 5-ASA for induction plus topical therapy, and I'll just show you some of those slides. And this is an observational study again, which really says much of the same things. There's a large study in the Netherlands. It looks mild to moderate UC. About 150 patients were enrolled in this trial with newly diagnosed, most of the newly diagnosed UC. And again, those on higher dose also had a lower chance of recurrence than those on lower dose, and longer treatment duration was associated with reduced recurrence risk. And we can talk a little bit about how long we go on to treatment. So these people got high dose induction, more than 4 grams a day, but they also continued on that higher dose, and more than 4 grams a day was associated with lower risk of relapse. Now, in my own practice, some of the guidelines will say you give high dose induction, then after induction, which could be 8 weeks, you can drop down to maintenance. I actually tend to wait, and I often leave patients on the induction dose for the best part of the first year, and then sort of have a conversation about dose reduction. I think one of the things that we don't do very often, I'd really be interested in your experience on the line, is whether you sort of counsel patients about topical therapy. Because when I first qualified, we did this in everybody. Everybody got all 5-ASA, high dose. Everybody got enemas on top, and that was at a time that we only had infliximab, the advanced therapy. So, I think part of it was driven by we didn't really have many ways to go, and we really wanted patients to maximize the treatment that we're on before escalating. Now, that principle should be the same today. I guess we get lazy around that principle sometimes because we have lots of agents, which is good for patients, of course. But there is a lot of disease that could be controlled by maximizing 5-ASAs, of course. And so obviously nobody wants to take topical therapy every day. I don't think any patient will put their hand up to do it, but part of it is education. We tend to prescribe it, and then we don't educate patients around it. Now, before I moved to Canada, which is 9 years ago, when I was in Oxford, we had in the clinic, it was like an old toolbox that you'd put your kind of power tools in, and in that there was all the different brands of enemas were in there, so patients could actually see what the applications looked like. So the IBD nurses, and the model of care is different. IBD nurses are funded by the hospital, and there's 5, 6, 7, 8 of them in every hospital. If you prescribed an enema, they would see the IBD nurse, and they would actually hold the enemas and see them and feel them and have an education session around how you administer them. And that's a question I have for you all. Maybe you can type in the box as you're going, or ask you at the end, how many times have you sat and had that one-on-one education about using topical therapy? But all the evidence shows that if you use combinations, better than monotherapy. And here's one of the trials. This is an important trial, which PINT study, which looked at pentasa 2 grams twice a day plus an enema, versus 2 grams twice a day and placebo enema. And you see that there's incremental benefit for both remission and response in combination by almost 50% increase than monotherapy. So again, that's important to know that if patients not quite, if you haven't done it out of the gate, you have the option to add it on. And similarly, a lot of the symptoms that people have with ulcerative colitis are rectal symptoms. They have tenesmus, they have bleeding, urgency comes from the rectum often. And the other thing that this study showed is that the time to cessation of rectal bleeding is always better when you do combination therapy, i.e. they'll more likely to stop bleeding earlier on. And I think this trial is really saying the same thing. So you can maximize 5-ASA therapy, of course. Sometimes patients are, on that and they're doing on 5-ASA and they're doing okay, or you maximize the 5-ASA, but they're not quite there. And often what we do as the next step is add on some local steroids rather than systemic steroids. And of course, budesonide is one such steroid, or Entocort as you know it. Obviously, there are differences between the two drugs, and the key difference being is that you get an extensive first pass metabolism of budesonide, so the systemic bioavailability is lower than prednisone. So that means it's less powerful because there's less of it in the bloodstream compared to prednisone. People feel great when you give them prednisone. But also the upside of it is that there's less side effects in the end because of that, what we call extensive first pass metabolism. And this is a study that's done of Cortimen, multi-matrix budesonide MMX, which is this you're very familiar with, and it's released in the colon, coating the colon. And this graph on the left shows where the coating occurs, and Cortimen gets much more exposure in the colon than the ileum, whereas standard budesonide Entocort gets much more exposure in the ileum than in the colon. The other nice thing about this is that it's a short fixed course of 60 days as you typically give, and there isn't very much in the way of adrenal suppression, and the slide that will show that. The other thing that we know about steroids is steroids don't induce mucosal healing, so people feel better with steroids, but steroids typically don't lead to mucosal healing. Now, we don't have trials of that today, but these are some of the older studies of Entocort which showed that. So this contribute study was add-on therapy. So this is the scenario that we see in clinic all the time. So you have a patient who's on 5-ASA, they've maximized the 5-ASA therapy, they're flaring, and then budesonide MMX was added onto those patients, and you see almost double the remission rates, clinical endoscopic remission of those patients after 8 weeks. Now you might say those rates aren't very high. Obviously, that's quite a high bar to have both clinical and endoscopic remission. Very few side effects. Because there's very little systemic absorption. And what it shows on the right here is that the morning plasma cortisol level, which is a measure of adrenal suppression, is only goes down a little bit in the Cortimen arm, but not below levels that would be concerning for adrenal insufficiency. So there's a bit of cortisol depression, but not lots. So optimally, we always want to give combination therapy oral and rectal and maximize the dose. So that's important. So if you're not at least 4 grams a day, make sure your patient is and tweak that up. Once a day dosing is absolutely fine, and once a day dosing ensures compliance. And of course, disease activity monitoring is done by the usual things. We don't see patients 4 weeks after starting therapy, but I think it's useful to get a fecal calprotectin in this setting. Of course, we do bring patients back for endoscopy, but it takes many months because of wait lists. Ultrasound for ulcerative colitis I think is used, but obviously there's not a great deal of ultrasound done in Canada outside 1 or 2 centres, but that will change, I think, over the coming years. And there's very favourable safety profile. So this patient got started on 4 grams a day or 5-ASA. He got budesonide, MMX, and formed Cortimen, and he's much better 8 weeks later. No bleeding, no pain, stools are formed. So then the question now is, what do you do next? When you have civil water? The question is, what do you do next here? Do you keep going on the high dose, or do you de-escalate the low dose? How do you discuss adherence? When do you reassess? All of those things. So as I said, in my own practice, I tend to keep them on the high dose induction therapy for the best part of a year, at least 6 months or so. There's only one thing that can happen when you reduce treatment: is the patient can flare. So so I tend, and particularly if it's had extensive disease, so I tend to keep going for a few months, and we'll have the discussion there. Remember, side effects to 5-ASAs are not dose dependent, and they're not temporally dependent, i.e. the main thing that can happen with 5-ASA is rare, is a small portion of patients that describe worsening of the diarrhea, and I think that's not common, it's rare. And then you have very rare things around nephrotoxicity, which we'll talk about in a subsequent slide. Just coming back, I talked at the start where sulfasalazine has these 2 components, aminosalicylic acid and sulfapyridine. but mesalamine is the active 5-ASA component is very, very safe. There's better safety profile than sulfasalazine, where it tends to generate most of the side effects. But worsening of diarrhea is the most common one. Then you get rare things like, nausea, flatulence, diarrhea. Those may be disease related rather than drug related, but they're there. And again, it's not associated with dosing, formulation, or duration. This was a paper that we published a few years ago now, about 5 or 6 years ago. I was really trying to get at this forever question, do 5-ASAs cause nephrotoxicity or kidney injury? And the data is mixed, actually, when you go back to all these population-based studies. But we did a massive registry-based study from the UK, which had 35,000 patients in it. And it was very rare to get nephrotoxicity with this drug. And it's an idiosyncratic reaction. It's interstitial nephritis. 12 cases per 1,000 person years. So a person has to be taking drug for equivalent of 1,000 years, and there's 12 cases in that period. So it was incredibly rare, but if it happens, obviously it's the outcome of that can be poor. What we found in this study, that those at greatest risk were those with cardiovascular disease, diabetes, or use of nephrotoxic drugs. So again, the chance of this is incredibly rare. You do have to tell patients about it, and they should have their kidney function tested once, maybe twice a year at max. When you come down to maintenance dosing, and there's various different guidelines, but the maintenance dosing is at least 2 grams per day, and typically 2 grams a day. So high dose induction at 4 grams a day, maintenance and about 2 grams per day, or a little bit less sometimes, but 1.5 to 2, depending on which studies you look at. And again, these are a meta-analysis of 4 trials, which again just shows that maintenance of remission of standard dosing, about 2 grams was better than less than 2 grams. This is a more recent AGA technical review, and again it says the same thing. Standard dose mesalamine was superior to low dose mesalamine, where standard dose 2 to 3 grams and low dose is less than 2 grams. So you really want to be looking at 2 grams per day as maintenance. I think we're all very familiar with the concept of mucosal healing. You've heard this at every talk and every conference, and we know that people who get mucosal healing are more likely to be free from complications downstream. The biggest issue when you take pills, however, is adherence, and we're going to start reliving this era now that we have small molecules like JAK inhibitors and S1P inhibitors that you'll see lots in your clinics now, and the physicians are prescribing them all the time. And we've known from lots of evidence from 5-ASAs that when compliance drops, you're more likely to flare. So, there's a number of ways of trying to improve compliance, and I think the first thing is education. Telling people you've got mild to moderate disease, which is good. And I always say you've got mild to moderate disease. The chances it will stay on mild to moderate, and you'll live a normal quality of life overall if you take tablets, and these tablets are very, very safe to take. And it's human. I know it's human nature that you'll stop taking your pills, or when you're feeling well. But I think that aspect of education is really important. The question that I asked about, a patient comes in the room and they're on 5-ASAs, and I'll say, what drug are you on? And they'll tell me which 5-ASA they're on, what dose are you taking, and say, how dose you're on. And I think you have to. I think also in the way you phrase it. If you say to somebody, are you compliant and do you take your pills? I mean, people get defensive, right? They're going to say yes. And I would typically frame it and say, it's a lot of pills to take in a day, and sometimes we can forget because life's busy. Do you think in a typical 7-day week, how many days in the week do you think you always take your tablets? And I think if you phrase it that way, 9 times out of 10, the patient says, I probably take it 4 or 5 days a week. I think it's rare that when you put the question like that in a non-judgmental or not a defensive way for the patient, I think most of them will say, look, I'm not always compliant, which is fine. But I think you really want to be aiming for, obviously, perfect compliance, but you want to be aiming for compliance at least 80% of the time, is not arbitrarily, I would say. And so you can improve that through once daily dosing for sure. And there's a number of patients that you'll see that are historically taking in divided doses, and I think you can just remind them to take it once a day. And there's been trials looking at that, and it's the same, taking it once a day or twice a day or 3 times a day. Excuse me. So everyone's familiar with the STRIDE guidelines, and these are about when you start therapy, patients should feel well in the first few weeks, then their biomarkers should normalize, and then their endoscopy and should normalize, and eventually we might target histology in Crohn's disease. There's ongoing studies looking at that. So this patient starts 5-ASA. His 9 months later, he's feeling well. His calprotectin is 70, which is great. That's a result. If his calprotectin was elevated, I don't know, 270 or 370 or 470, I think I would just ensure that he's compliant. And if he's not compliant, try and sort of encourage compliance or up the dose a little bit, or perhaps even add some topical therapy. But I'd certainly want to bring that patient up for sigmoidoscopy and see how things look. So remember, we get calprotectins all the time. They land on our desks, often we don't even ask for them, and they end up on the desk, particularly in patients on advanced therapies. But calprotectin accounts for the majority of protein content in neutrophils. Remember, neutrophils are inflammatory cells in the gut, in the lamina propria and the epithelium lining of the gut, and they're shed in the stool. Remember, when we take biopsies and histology biopsies, the predominant driver of the scores is actually neutrophils. So calprotectin is in some ways a kind of an indirect marker of histology as well. So calprotectin is better than CRP at detecting inflammation. We know CRP doesn't always go up that high in UC anyway, unless they're very sick. Calprotectin is more accurate in UC than it is in Crohn's disease, and there are lots of different cutoffs depending upon which studies you look at, which guidelines. But I think 150 is probably the right cutoff overall of being associated with reduction in flares compared to other levels. So this was a sort of a Delphi consensus study around optimizing management 5-ASAs. And here's the kind of algorithm here on the right. So I'll just sort of get the pointer again here. Maybe a moment. So here it's saying, the patient should start on more than 2 grams a day. Are they in remission? Yes, and that means they feel well and the calprotectin is normal. And if so, you can probably maintain on 2 grams a day. They're not in remission, make sure they're on 4 grams a day and topical therapy. If they're in remission, yes, check the calpro, yes, you can drop down to 2 grams. If they're not in remission, this is then the sort of patient that you add on Fortiment to and do the same thing. So I think this is actually a very useful practical guideline. I think we know this well, that mucosal healing is associated with fewer complications. So this is a meta-analysis looking at people who achieve mucosal healing after advanced therapy versus not. It's always fewer complications. And fecal cal has a pretty good correlation overall with endoscopic scoring indices as well. And similarly, it has a pretty good correlation with histopathology and detecting histological remission or not. So if you have a fecal cal of less than 100, there's a pretty high chance that you're going to be in histological remission as well. Now, this is interesting. I mean, I think there's the vast majority of studies all do show that they're all observational, that patients who are in histological remission are less likely to have a relapse compared to patients in just endoscopic remission. This is a study from McMaster which showed something different to that there wasn't any additive benefit. And in the end, we need randomized studies to look at this. And that's what Verdict is doing, a trial that I'm leading with many other colleagues, looking at treating to histological healing, trying to answer that question. When you're looking at these ROC curves, receiver operating curves, what you want to see is this purple thing up here in the top left on both sides. That's the ideal. So these area under the curves, 0.6, you want to see them up at 0.8 ideally. But this is not bad, and it's reasonable at predicting histological remission, fecal calprotectin. So just as a sort of practical guideline, if your fecal cal is more than 250, there's likely some inflammation in the gut. Often it's microscopic inflammation. If it's 100 to 250, there might be some inflammation. You might want to take the patient and do a sigmoidoscopy, for example. And if it's less than 100, it's likely that they're in remission. And there are other things that can interfere with fecal calprotectin for sure. And there's a few things. One is you often see your time of day. So if patients are asked to take their first stool sample, so early morning stool sample, there's actual variation throughout the day in your fecal calprotectin level. And if you took two different samples, you get slightly different answers. Improper storage and handling, if it sits around for days before it goes to the lab, that will affect things. If you've got a very diluted stool sample, as well, that can lead to kind of false results as well. And patients taking aspirin or non-steroidals, and that can also affect it too. So, just thinking about summarizing how you think of patient in front of you, which is remember the majority of people have mild to moderate UC. You may only see these patients once a year and follow up, but the key things, I always say we want to keep you on this drug as long as possible and not have to escalate to the next therapy because they're a lot more involved. And that always resonates with patients. And then you're saying, well, these are the things that we're going to do to try and optimize things. And they are make sure you're on the right dose, make sure you're compliant, making sure you take it once a day rather than several times a day. And at induction, making sure you have topical therapy as well as oral therapy as well. And like all sort of advanced therapies, you're trying to induce mucosal healing and have an endoscopy score of 0 and normal fecal calprotectin. So this is again another one of several algorithms, and this is mild to moderate UC. If you've got mild disease, again, this talks about at least 2.4, more than 2 grams essentially, and then you go into maintenance dose. Here's the moderate to severe algorithms. This is really kind of saying the same as what I've said on the previous slides already. Maybe I'll ask at the end any of the referring colleagues if they want to comment on this, but you may have these kits in your clinics, which are these starter kits. I think the nice thing about having these is if you have them, patients can take something there and then on the day, and there's a 1-week course of oral 5-ASA, and there's a 1-week course of suppositories as well. And there's an education booklet around that too. So that's one on the left, which has suppository S, one on the right, E, has oral 5-ASA plus an enema. So how do you pick which one you want to choose? Remember, if the patient has proctitis only, there's no point in giving them an enema. And again, this is one of the things that sometimes patients haven't quite improved and still got a lot of symptoms on the rectum. Why? Well, if you put the nozzle in the rectum and you squeeze, we know for scintigraphic studies that the enema goes up to the splenic flexure. But what you're probably missing is enough treatment in the rectum itself. So suppository, if you've got just proctitis, the patient needs a suppository, not an enema. If you've got disease beyond the rectum, then the enema is more indicated. That's not very. And I think this sort of starter kit has a lot of education for the patients about what the condition is, how the drug works, treatment goals, adherence, managing flares, and so on. So very useful, I think. And this is another example of what's in there. It teaches patients around where the inflammation is. You'll have pictures like this in clinic. In the rectum, this is probably in the left side, or pancolitis, which is extensive here. And it really also talks about the various symptoms that people may have. It also gives some education around treatment goals as well. So, remember, these are the discussions that we're supposed to have in clinic, and we don't always have time, or we don't always spend as much time as we would like to with every single patient. And I think that's honest, and that's real life. But I think this is quite useful. I've seen this, and it's got fairly useful information in it around treatment goals. Excuse me, around treatment goals of symptomatic normalization, biomarker and calprotectin normalization and endoscopy. And it also really tries to educate patients about adherence too, which I think is really key for this class of drug. Also tells you about managing flares, how to sort of keep, how to reduce irritation from multiple bowel movements. So, moist towels, sitz baths sometimes for patients, particularly raw around the rectum area. NSAIDs are actually okay in inflammatory bowel disease. Occasional use of NSAIDs is fine. Again, it's a myth that you can never use an NSAID. Occasional use is fine, and there's studies to show that. there's some general dietary and general dietary advice, nothing specific to IBD, but common sense stuff as well. And then things around, flares are often caused by stress, excessive alcohol, lack of sleep, common sense stuff. But we know that all of these things can trigger IBD flares. Okay, so I think I'll stop there. We've got sort of 15 minutes or so for any questions or comments. So maybe Jennifer, maybe while there are some questions, but maybe I could just ask the question I had. So how many people or do you get the chance to sit with patients and educate them about how to use topical therapy, or do you think this is like a dead art, nobody does it anymore? My feeling is it's a dead art. Like when I speak to the trainees today, they'll look at me blankly when I say talk to a patient about an enema. But I mean, do you think we do it? Do you think that it was ever done, or is it a bit of a void in education? So maybe Jennifer, your comments and others too.
Yeah, I think it is a hit and miss from a nursing perspective. And I have a luxury of having a clinic that's a little bit longer with the patients than perhaps you would have. I try to spend that time reviewing it. Even over the phone, we have conversations about how to use its like rectal preparations, because I think that is a big part of adherence. I think they don't understand how to use it, or perhaps they've had a bad experience with it in the past. So, spending that time, I always feel that you pay now or you pay later. So if you spend the time up front really educating the patient, that it will work out better in the long run. And I always try to remind them that the first few times they do it may not be a really great experience. They may have accidents and things like that, but just try to reassure them that the more they keep working at it, it hopefully will get better. And a lot of people will come back and tell me that.
Yeah, and I think the other thing to say is that it's obvious some patients just physically can't do it. You'll come across patients who, for physical reasons, can't reach their bottom, right? They physically can't put it in, or they've got dexterity problems and they can't do it, or they've got really bad fecal tone or incontinence and they just cannot keep the enema in, right? And sometimes in older patients, and there's no point in pushing that. That's the obvious stuff. But the thing that I'll say that it does help the tenesmus symptoms, and there's one study which we didn't show, but even if you take it 2 or 3 times a week, it's better than not taking it as well. And so for in my practice, people who just have proctitis only, and maybe they've not needed an oral therapy or they've come off the oral therapy, their maintenance treatment is a suppository 3 times a week. So I know you're not going to take it every day, you probably don't need it every day, but take it every day until you stop bleeding, and then once you stop bleeding and your symptoms improve, take it 3 times a week as a maintenance at least, because it's very rare that someone's going to do this every day, because they have life to live as well. So yeah, but I do think sometimes spent with education is important. So yeah, good.
I have a couple of questions of my own, but we'll do the audience first. My colleague Barbara Curry from Nova Scotia, she has a question for you. Does rectal bleeding from internal hemorrhoids elevate fecal calprotectin in the absence of active IBD? My understanding is that the presence of blood alone, given that it does have white blood cells, can falsely elevate fecal calprotectin.
Yeah, it's a good question, and I'm not sure if there's been a study that's really looked at that, but in theory it shouldn't, because you're measuring neutrophils in the epithelium predominantly. So I think if you've got absolutely no inflammation in the gut, just blood alone from a hemorrhoid should not elevate your fecal cal. So we see this. And maybe your question is going towards, we have patients all the time who say they bleed, and when you scope them and you often can't see it, right? And what's the source of bleeding when you can't see it? And I do wonder whether there's often a tiny rim of anal rectal bleeding or small mucosal tear or something. But in theory, your calpro should be normal. Where you do see really high calpros in the thousands and thousands, often in proctitis. Remember, in children it's normal to see calprotectins in the thousands. In adults, we don't see calprotectins levels of 10,000 like you see in children. But where I have seen calprotectins in the 2,000-3,000s often is in people with really bad residual proctitis. And I just wonder whether it's kind of just a mucosal retention thing, right? That it's really distal. There's a lot of neutrophils being released. It kind of gathers in the stool sample. So you sometimes see it there.
Thank you. My colleague Sarah Moore from Hamilton. She's asking, when adding on rectal therapy to oral 5-ASA during a flare, how long do you add this on for, and do you taper when coming off? Like every other day to 2 to 3 times per week? I think you kind of answered that a little bit there. Or do you just advise them to come off after a certain amount of time?
Yeah, no, it's a great question. I think it's, I mean, if the trials that were done were for 8 weeks of combination therapy, but I think that's quite a lot. Um, you know, I think it's hard from a compliance perspective, but in theory, I mean, if it's working, it really should be eight weeks of therapy. But what I say to them is, you're on your high dose oral. I want you to take this every day for a month if you can. I give them a 30-day script, and then if your bleeding's gone, and really what you're left with is symptoms of mucus, urgency, that kind of thing, then keep taking it, but try to do it on alternate days at least. So ideally, you take it for 2 months. I can't remember the last time I met a patient that will do that, and that's understandable. But we try and do it for 30 days, and then I think to alternate therapy, and from there, alternate days.
Very good. Mary Louise Martin from Calgary. With the availability and accessibility of biologics, do you think we are jumping to biologicals too early for our mild disease patients instead of optimizing our 5-ASA drugs?
Yeah, it's difficult to know. I mean, I think the temptation's probably there to escalate things because you can, and we're spoiled in Canada because you can essentially go from a 5-ASA to a biologic without any in-between step, or you can go straight because it's conventional therapy, and you see it's not in Crohn's disease, but you can essentially go there. But in most parts of the world, you can't do that. There are steps that you have to go through, and you have to use steroids, and you have to use azathioprine and methotrexate, those sorts of things. Still, in most parts of the world. So I think we have the ability to jump earlier for sure. Doesn't mean that we're doing it. I don't know. I'm not aware of a study that suggests. I don't even know how you design that in the study itself. But I think the patient that needs advanced therapy. It's the usual clinical parameters. But I think sure. I think we probably get a little bit lazy around maximizing these things and saying, go away and double your therapy and add on some topical therapy. So yeah, perhaps, but the same principle applies to advanced therapies as well. There's a risk that we become, like our dermatology colleagues can, where they can prescribe 10 different drugs and cycle through things. I think the same principles apply in IBD, that even if it's an advanced therapy, we should always maximize the dose, compliance, adding concomitant therapy before we switch or so on. I think the same applies here.
Usha Chohan, from my colleague from Hamilton, just wanted to make a comment to your earlier question, is that yes, nurses do spend the time talking about rectal therapy and how to administer it. And I absolutely agree with you, Usha. And Barbara Curry, again, just wanted to comment that she finds that if she suggests suppositories first to settle the most distal disease and reduce the urgency and tenesmus, this helps them to later be able to hold the enemas.
Yeah, I think it's a great point. So I think if you've got, to my earlier point, if it's just proctitis, don't use an enema. And I think that's one of the commonest mistakes I see when people have got residual symptoms. But in this scenario, if you've got more extensive disease and it's bad, I think I do have scenarios where I'll say use an enema maybe in the morning or at night, on a suppository the other time round. But I think you're absolutely right. And I think this is the art of nursing and medicine, right, rather than science here. It's if you're really struggling to retain, and those symptoms of extreme tenesmus are always the distal rectum. So yeah, I think it makes sense what you say there, to really maximize topical therapy and before you do the enema. Yeah.
Just a couple questions about the adverse side effects, and I know they're very safe medications, but is there any particular patient you wouldn't want to use them in? So I'm thinking like our patients with declining renal function. Are you afraid of using it in someone like that?
Yeah, I mean, I think you have to make a judgment call. So do I have patients with chronic kidney disease on aminosalicylates? Yes, because typically if it's the drug they need for mild to moderate disease. I don't think there's evidence that if you've got CKD from, I don't know, diabetes, giving them 5-ASA is more likely to tip you in the balances. It's a totally idiosyncratic reaction. I think you have to be a bit more cautious, and you probably have to have closer monitoring. So I think if you do have established CKD, I think I would pick up the phone to the nephrologist to make sure they don't have an issue with it. It's very rare. The absolute chance of nephrotoxicity is very, very rare, but it's serious if it happens. And even the practice of checking their creatinine and urea once or twice a year. Well, I think we're treating ourselves more than the patient, because if it's idiosyncratic, it can happen at any time. In the olden days, people actually used to do proteinuria and dipstick patients' urine on 5-ASAs. And certainly where I trained, that's what we would do. Patients would also have a proteinuria to make sure there's no early signs. So, but I think it's a bare standard of practice that you should check their kidney function at least once a year. Are there other groups, other than if it was a known intolerance? I can't think of really any other groups where you wouldn't use it, unless they really couldn't swallow pills because they have a swallowing problem, or they just can't get them down. And I think that's, again, rare.
Being a little bit of a devil's advocate, what's your thoughts about using 5-ASAs with Crohn's disease? We all have patients that we've inherited or come to us on them. I just wanted to know what your comment on that. We get lots of opinions from key opinion leaders. I'd love to hear yours.
Yeah, I mean, I've published probably a dozen papers on this. We've done a lot of work on this over the years. And I think the first thing to say is the use has declined for sure. In Canada, it's declined. It hasn't in the US, interestingly. And if you look at some of the population-based studies in the US, it's still the most commonly used drug in Crohn's disease. That's because most people have mild IBD and not moderate severe IBD. The centres that we all practice on the line, you think everybody has severe IBD, but they don't. I mean, the vast majority of mild to moderate disease. UC is easier, right, because you've got a treatment that is known to work for mild to moderate disease. I think Crohn's is a bit harder because I don't think we typically classify what mild Crohn's is, and it's different because you've got the patients with ileal ulcers only that could be mild, or you have the patients with patchy colonic disease throughout, and they have different symptoms as well. So, what are your treatment choices when you see a patient with mild Crohn's disease? So, do I use 5-ASAs in them today? No, I don't. I haven't prescribed it for that condition for probably a decade. Do I have patients on it? Legacy patients, yes, very few, but they are on it and they feel well and they don't want to come off it. Of all the trials that were done for Crohn's disease, the only one that showed benefit was sulfasalazine, not 5-ASA. So it's actually sulfasalazine, and it was in patients with mild colonic Crohn's disease, and it was a very old study before the days of endoscopy and so on. But in the end, if you've got a patient with sort of very mild, superficial, patchy colonic Crohn's disease that looks a bit like UC, which it does sometimes, typically, Entocort would of course be fine for ileal disease, but I don't think you're doing anything wrong if you give them a low dose 5-ASA, and I think people do that, and we all have patients in whom it works on. Is there evidence to use it? No, there isn't. All of the trials show it worked, but have you all got individual patients where it might have worked? Probably. Most often, I will give people with ileal ulcers a one-off course of Entocort, and then you might have to repeat that every 2 or 3 years, or go into something else. Often it's fine. Or if they've got very mild colonic Crohn's, I might just give them MMX. So yeah, I'd be interested. I mean, do you see it used in your own centres often?
Yeah, I've inherited from some people who've retired. We've inherited some patients, like call them legacy patients, that come in with being on 5-ASA. They're feeling quite well, and they don't really see any need to change. And I have a hard time trying to convince them to change. So kind of just leave them alone with that, and hope that they continue to do well.
Yeah. Yeah, and I think it will remain one of those unanswered questions, but in the absence of an effective treatment in mild to moderate Crohn's, and you've got something so safe, you can understand why it's used in certain circumstances. But I really think it's probably the very mild patchy colonic disease where you might use it.
I did just want to quickly comment on the kits that you showed at the end of your presentation, the suppositories and the enema kits. And I just received them in our clinic as well. And what I'm trying to do is get them put into the endoscopy clinics, because I find maybe not just the gastroenterologist, but our surgery colleagues could benefit from that as well, by at least sending them out of the department with a starter of some medication before they get the referral to see a gastroenterologist. So I don't know if anybody else has tried that, but perhaps that may be of a benefit for them as well.
It's a great point. I think important point for Ferring to get those out there. I mean, I don't know from where your practice, but in Ontario, most colonoscopy is done by surgeons, right? So 60% of colonoscopy in the whole province is done by surgeons, not gastroenterologists. So surgeons diagnose more UC than gastroenterologists, in that reason, and that's the ideal. That's the ideal scenario to have these things, because as we all know, the wait times to see a specialist in Canada are not good for any condition. So that, somebody getting on a starter pack, 5 ASAs, I think it is perfect in that scenario.
Great. Okay, I don't think I see any other questions from the audience. Just double check. No, I don't have any more, but I just wanted to thank you very, very much for spending your evening with us and sharing your expertise on, I think, a topic that is really relevant and important for us to be aware of. I also wanted to thank the audience for spending their evening with us. If you or your colleagues want to watch a recording of this, it will be available on our website in the coming days. CanIBD has a YouTube channel, so it will be found there as well. So, and I'm getting lots of thank yous from everybody in the audience. And thank you again, and everyone have a lovely evening.
Yeah, thanks a lot. Thanks for joining. Thanks to the Ferring team for supporting this. It's great. Thank you.